All right. Hi, everyone, and welcome to today's Student-Led Journal Club presentation. Today, I will be introducing student Dr. Alan Lam. Student Dr. Lam is a first-year medical student at Kansas City University. He spent his undergraduate years at the University of Florida studying applied physiology and kinesiology, with previous research background in biomechanics and emotional regulation affecting motor performance. Alan is currently interested in pursuing orthopedic surgery and sports medicine. During his free time, student Dr. Lam enjoys weightlifting, ultimate frisbee, and hiking trails. So with that, student Dr. Lam, please take it away.
All right, thanks so much, Anne-Marie. Thanks everyone again for joining me on a Friday afternoon. Today I'll be going over some of the research that I did during my gap year with an orthopedic physician back at home in Jacksonville, Florida, about early tibial component fractures and the titanium implant of total knee arthroplasty. And just as Anne-Marie said a little bit about myself, graduated from the University of Florida in 2019. During my free time, I like to weight lift. This is me at the Strong Barbell Club in Kansas City on the right. And during some of my longer breaks, I like to go out hiking. This is me with a couple of friends back in the Smoky Mountains a couple years back during the summer. It was a good time. Now, just for a general overview of what we'll be covering today, I'll be giving a brief introduction to total knee arthroplasty, or also known as total knee replacement. We'll be going over two unique cases where we see a specific type of knee replacement complication. We'll talk about the significance of these two cases, as well as break down some of the reasons why it may have occurred. This is just a disclosure slide. And now for just a general introduction to total knee arthroplasty to get everyone on the same page. This is a very common orthopedic procedure. The primary indication of it is going to be severe end-stage osteoarthritis. Now, osteoarthritis is your progressive wear and tear disease of the joint. This can generally happen over time due to age. Sometimes it can be accelerated with other factors like playing sports or some traumatic events. But this is when the articular cartilage on the femur and tibia start to wear down over time. And with the end stage part, you eventually have a bone-on-bone articulation where the bones are touching and there's no more cushioning or support between the two. So what the procedure entails is a resurfacing, shaving away of that diseased articular cartilage using various instruments. You're going to have a combination of metal and plastic or polyethylene components that go over the distal femur, the proximal tibia, as well as the undersurface of the patella. You also have a polyethylene liner that goes in between that femur and tibia portion, acts as sort of cushioning substitute for the meniscus. Now, I'd like to preface this by saying that we don't jump into surgery. This is usually after a failure of conservative treatment measures. So in orthopedics for knees, you can have cortisone injections, you can prescribe the patient physical therapy, as well as knee braces to provide some more stability for osteoarthritis. You can also have some other different types of newer injections, gel injections, as well as platelet-rich plasma in an effort to try and restore the cartilage growth. But in the end, when all else fails, that's when we would approach the patient and talk about a surgery like knee replacement. Now, given that knees are the most commonly afflicted joint of osteoarthritis, we've seen this procedure become more prevalent. Another interesting trend that's been seen over the 70 years that knee replacements have existed is that the mean age of patients who are receiving them is actually decreasing. Generally, you see that the older population will get this type of procedure, but as we accumulate the data over time, we've seen that mean age is dropping. That's an important detail that I'd like to hold on to throughout this intro. Now that I've gone over a general overview, I'd like to share what osteoarthritis can look like. And I'll start off with a pair of normal X-rays. So with my laser here on the left, you have anterior posterior X-rays of the bilateral knees. You're mainly dealing with two articulations. One is going to be your tibiofemoral articulation of the knee between the femur and tibia, of course. You have your medial compartment right here, lateral compartment right here. You also have the patellofemoral articulation, of course, between the patella and femur. Now, this is an example of healthy joint space. You see a good transparency between the bones. That indicates that there's cartilage existing between them. There's no evidence of joint space narrowing. The knees are intact. These knees have no osteoarthritis. So now that we know what normal looks like, I'd like to share what abnormal looks like, what knees with osteoarthritis look like. So with these next x-rays, you have severe bilateral bone-on-bone osteoarthritis. You can see where we had healthy space of cartilage in between the bones before. There is a lack thereof, in fact, a complete collapse of the medial, lateral, as well as patellofemoral joints. You see that the bone is beginning to deform. You have what are called osteophytes developing around the edges, where they start to bend due to the stress. And you even see the undersurface of the patella is starting to laterally maltract as it comes out of the femoral groove there. Even outside of the bone, you can see where the patient's legs are, they're beginning to become bowed. We call this a varus deformity. This is mainly due to in part from that bone-on-bone arthritis. And just to give a sort of pathological model of how this can occur, I have a figure on the next slide here that goes over some of this degeneration. This is from Dr. Lee et al. On his model of osteoarthritis pathogenesis. You see at the top here, we have the normal joint with healthy cartilage, healthy subchondral trabecular bone. And as it progresses from early stage to late stage osteoarthritis, you begin to see that cartilage degeneration as it gets progressively deteriorated over time. And you can see with the subchondral bone here, there's micro damage, increased porosity, as well as development of bone cysts, or essentially holes in the bone that can predispose the bone to failure. So now that we've gone over the problem, osteoarthritis, I want to talk about the solution. That brings us back to total knee replacement. And this is what a quick anatomy of what a total knee replacement looks like. This is actually the specific design we'll be talking about today. It's called a Stryker Triathlon Titanium Knee System. At the top here, you have the femoral component that goes over the distal aspect of the femur. You have the tibial component. Up top here is the base plate. Underneath is called the keel. And you have 4 pegs that go around that keel. You also have the polyethylene liner that serves as the cushion between the femur and tibia. And not pictured on the left, but what you can see here on the right is that piece of the patella that goes on the undersurface of it as it tracks through the femoral groove. Now that we know what a knee replacement looks like, I want to briefly go over some of the fixation methods that you can have in terms of implantation process. And mainly you're dealing with 2 methods here. We'll go over the first one. You have cemented. This is usually considered the gold standard of how you put in a knee replacement. I want to refer you to the figure on the upper right here. This is an x-ray of a total knee replacement in the knee. You can see this slight white discoloration on the proximal tibia. That's the evidence of the bone cement that's used to facilitate seating of that implant into the bone. Now, given that it's the longest standing fixation method for a total knee replacement, it has the most literature for having the highest survivability. These types of knee replacements has ranged from 20 to 25 years of being able to last in a patient's knee. However, with that long-standing survivability, there have been some concerns with long-term complications. So there's something called osteolysis or bone resorption, where the bone cement can begin to fail over time as the years progress, causing that component to loosen, and eventually patients may have to be brought in for a revision procedure where some of the components get swapped out. So a failure of that bone cement to be able to adequately hold the prosthesis to the bone can be a problem. And with how I told you to remember that detail of the trend where mean age of patients are getting younger, this is where the second method comes in, a cementless. It's been growing in popularity, and as it suggests, you're not using any bone cement to seed that implant into bone. So I have with these two lower figures, you can see with the specific design we'll be talking about today, but you have no white discoloration or interface. This implant is seated directly into the bone. There's been some technologies that have evolved over time to help facilitate utilizing these younger patients' better bone stock to seed into that bone. Some of these designs use what's called a porous surface that's put in place on the undersurface of the tibial base plate. It's almost as like it has tiny holes in it. That encourages better intradigitation of the bone and better ingrowth. You can also have 3D printing technology that's been implemented into some of the more recent designs within the past 10 to 12 years, as opposed to how they used to do it, where you can more custom fit these implants to the patient's bone. And you can also have a different type of metal implemented. So before, back around 20, 30 years ago, they used what's called cobalt chromium as a type of metal for the tibial components. And although it is a slightly stronger metal to what we'll be talking about today, titanium, titanium has the superiority of having a better opportunity for bony ingrowth, and that's the interdigitation of the bone that helps with the osseointegration of having that implant seed faster and stay stuck in the bone to ensure better long-term results. And given some of these fixation methods, I want to talk about the complication we'll be focusing on today. Those are component fractures. Now, out of the various types of complications you can have after knee replacements, this is one of the more rare ones. In fact, in a study we looked at in the literature taken between 1992 and 2016, between 25,000 registered knees, there was only an occurrence less than 0.2% of tibial component fractures. That's where the metal itself has broken within the knee after it's been placed. Now, this used to occur more regularly in the past, say the late 90s, but of course with evolution in how the prosthetics have been designed with both cemented and cementless, as well as the materials of the metals produced, the quality of them, the occurrence of these tibial fractures have become increasingly rare in recent years. And to this date, for our specific design we'll be talking about today, there have been no documented cases of the fracture in literature, given some of the technologies associated with it, with 3D printing, with the highly porous undersurface, as well as with the titanium implantation. So I've finished covering the intro to total knee replacements. I now wanted to move on to the next segment. We'll be talking about our case presentations where we have two novel findings of a tibial component fracture with this specific design. I'll begin with the first case. She is a 60-year-old female status post of primary cementless left total knee performed back in 2017. She said she had been doing well, presented to clinic, however, 3 years later with a chief complaint of several months of worsening left knee pain as well as instability. There was no inciting episode or trauma that causes left knee pain. She does mention, however, that she noticed progressive bowing of the legs over time, as well as increased pain and stiffness with any sort of weight bearing on that left leg. Some of her past medical history includes hypertension, migraine, obesity, as well as an episode of bacterial meningitis that occurred in early 2020, the year that she came in. However, that was resolved well with an ENT physician that eventually needed sinus surgery. Excuse me. But she had been cleared before coming into clinic after that episode. For her medications, she takes lisinopril and gabapentin for the hypertension and migraine respectively. And for allergies, she has allergies to sulfa. Now for that office visit upon physical exam, she presented with an antalgic gait, with use of a walker that was not present after her first knee replacement. She was also using bilateral knee braces to provide more stability. Upon inspection of the left knee, there was a well-healed incision where the knee replacement was, with mild swelling, no significant evidence of any acute infection. Looking at the range of motion bilaterally, she was 0 to 120 degrees passive range of motion, but painful on that left knee with additional medial sided tenderness. Upon specialty testing, she tested positive for anterior posterior drawer testing as well as positive varus instability. Now at this same office visit, we took radiographs, and that's what I'll be covering next. And this actually gives us a nice picture as to what is starting to go wrong here. So of course, on the left knee, we can see the knee replacement. We do have an abnormal angulation. We can see that varus deformity, or the outward bowing of this leg, anterior posterior view. And if we look at the lateral view, this is even more telling. You can see that the anterior tibia is now subluxed forward as the femur rolled back. You can see these two white lines here. This is actually the locking mechanism for the polyethylene liner that shows transparent in the X-ray. But when you see this, that's actually an indication that this plastic liner itself has completely disengaged from the tibial component here. And now after these radiographs we took, the physician ordered a CT scan, and I think this is where you can see that fracture best. So I'll begin on the left here. We have the sagittal view of the CT scan for the patient's knee. And as we come lateral, we see the fibula here to medial. You can see a linear signal right at that point, and I'm going across it right there, where there's evidence of that fracture of that medial portion of the tibial base plate. You can also see the anterior tibial subluxation here as the femur is displaced posteriorly. So I'll keep that there. Now, coronal view, this is going from anterior to posterior. You can also see that linear signal where there's that angulation of the medial portion of the component and that linearity that suggests the fracture. Even beneath it, you can start to see a little bit of a subcortical reaction where there's additional stress placed on the underlying bone of the medial tibial component. And then lastly, with the horizontal view, we'll go from superior to inferior. You can see it clearly right there, that it's broken right through. And then the additional subcortical reaction due to the increased stress from the tibial component. Now, these are great at looking at snapshots for when the fracture happened, but I also want to look over the progression of the X-rays. How did it get to this? So these pictures overall can give us a clear signal of how this eventually deteriorated. But I'll begin with the first slide here for case 1. These are her preoperative X-rays before that primary knee replacement. You can see the severe medial osteoarthritis on this left knee. The surgeon restored it in the second and third figure here. These are 1 month post-op X-rays. They have better alignment. The varus deformity seen preoperatively is fixed. These are seated well into bone, given it's the 1 month post-op. And even with the 1 year post-op X-rays, it's hard to see, but if you would zoom in closely to the keel portion of this base plate, there's evidence of a slight radiolucent line, but the surgeon deemed it as within normal limits. Additionally, the patient was asymptomatic, so there was no over concern for this slight radiolucency on the tibial component. But then when we jump back to that present office visit, we can clearly see what happened with the abnormal angulation, the medial tibial deviation consistent with the fracture, as well as that subluxation. Now, going over intraoperatively, she eventually needed to get a revision knee replacement of that tibial component. We can see in here that clear failure of the medial portion of the tibial base plate. And this is actually very interesting on this second picture here. On this medial portion, you see where the porous undersurface is of this tibial component. You see no evidence of any bony ingrowth. The bone had failed to interdigitate with the specific type of design. But however, on this lateral portion of the tibial base plate, you can see that bone was able to successfully seat itself in there. Now, with details of the revision, this is how it eventually looked. I'll talk you over through this real quick, but the entirety of the tibial component got swapped out. There was a longer tibial stem that seated deeper into the proximal tibia, as well as implementation of bone cement to help with the stability of that tibial component. And due to some of the defect that we found medially during surgery, there had to be what's called a cone augmentation right here, this thickened part underneath the base plate that serves as a wider area to cover the bone and substitute that area of bone defect we found on the medial side. Now I'll go over our second case next. This one was a 65-year-old male status post primary cementless right total knee replacement in 2017 with an even shorter length of time to the office visit. He presented 16 months later with progressive pain and instability. There was also no inciting event with case 2, but he had constant pain with weight bearing on that right leg. He was able to walk without a cane and walker within the first several months of his knee replacement in 2017, but now regressed to use of those assisted devices. Some of his past medical history includes atrial fibrillation, hypertension, as well as obesity. For medications, he was taking Xarelto, hydrochlorothiazide for that AFib and hypertension, and he had allergies to tetracycline. Now, looking at the second case's physical exam, he had an antalgic gait using a walker for gait assistance. Right knee inspection showed a well-healed incision, only mild swelling and effusion. Upon palpation, there was tenderness of the tibial tubercle as well as pes anserinus. Looking at his range of motion for that right side, it was painful passive range of motion 0 to 120 degrees. Labs of sed rate and CRP were taken negative for any heightened inflammatory markers, so we did not suspect any acute infection. There was also a bone scan ordered that showed increased blood flow uptake into that right knee, which was consistent with some of the radiograph findings we saw during this office visit, which I'll show you next. So now we have the second case's x-rays here. We again see this abnormal angulation of a slight varus deformity on that right side. It looks as if the femur is sinking, or the tibia component is sinking underneath the femur. It might be more apparent on this lateral view where we can clearly see this evidence of radiolucency around the keel portion, a transparent line where the bone did not take onto the implant. You also see this anterior lifting of the tibial base plate where it actually fractured right between the junction of this base plate here, as well as the keel. And you can see as it angles upwards, you have this posterior tibial involvement of the bone where the component is beginning to dig into that posterior portion of the tibia. Now, again, just like the first case, I'd like to show you the progression of how this came to be with this next slide. Similarly, we also have the preoperative x-rays before the first knee replacement. You can see that there is severe lateral osteoarthritis of that right knee, excuse me, with eventual 1 month post-op x-rays showing better restoration of that malalignment. But then again, when we look at on this first row, the 6 months and the 16 months x-ray in comparison, you can see that there is a gradual lifting of that base plate. Whereas he was asymptomatic on 6 months, there was no overt cause of concern. There was definite cause of concern once he came in with the symptoms of pain, instability, and the clear fractures seen on that X-ray here. Now, given for the solution, revision surgery had to be done where the tibial component was also similarly replaced. We can see here intraoperatively, there was a medial defect in the bone here, lack of bony ingrowth on that porosity of the base plate. That eventually had to be swapped out with a longer tibial stem, a cone augmentation to fill in that bone defect. And after 2 years of this revision, he had been doing well. And he also has left knee replacement that was performed during that time frame. Now that I've gone over some of the case presentations, I sort of wanted to deconstruct some of these findings, talk about what happened, what was the cause, what were some factors that contributed to this. And I wanted to start off with the case significance. With this specific type of implant design, we found the first occurrence of a tibial component failure, given its specificity of being cementless, being 3D printed, as well as having a highly porous undersurface while being composed of titanium. This is relatively unique because this was a short-term complication, differs from your usual long-term complications that you see in knee replacement, such as the osteolysis, such as the polyethylene wear, such as loosening over time. And following up with the literature, the longest follow-up study that I could find included 341 cases of that Stryker Triathlon titanium knee system, a mean follow-up of 5.5 years, with only 11 revisions reported, none of which was a component fracture. I wanted to include this slide to talk about just a couple of the complications that come up even before a component fracture. Namely, we were most concerned about a certain type of prosthetic joint infection given the acute nature of some of their symptoms. And this can be a serious thing. I remember in the orthopedic clinic I was working at, there was a patient who had been dealing with PJI for almost a year with multiple knee revisions. Ultimately, the bacteria never left that implant. It stayed infected in that joint as well as the components. So what ended up happening was a knee arthrodesis had to be performed. That was complete elimination of the knee joint itself, fusion of that distal femur and proximal tibia together. So he can never bend that leg ever again. It's a serious thing, but given the findings, given some of the lab markers that were taken, no acute inflammation found, we were able to eliminate that. We could also eliminate those long-term complications, the osteolysis, the polyethylene wear, metal ion release. This is a unique long-term complication you can have when there's metal to metal articulation causing a release of cobalt chromium ions, which can affect some of the surrounding tissue. But we could thankfully get rid of those because there was no evidence of polyethylene wear, no evidence of metal on metal articulation. So now that left us with possible aseptic loosening or a malaligned implant during implantation of the knee replacement. Now, ultimately, we attributed the mechanism of failure to be a fatigue fracture due to loss of focal bony support underneath that specific portion of the implant. So what had happened with the medial portion of that tibial component, that non-ingrown sign where no bone was seated into that porous structure, that had interacted with the portions of the component that had seated in, that had osteo-integrated with each other, and it created sort of a torsional stress or cantilever force that eventually, when compounded with weight-bearing asymmetrical forces, where you mainly place majority of your weight while walking, standing, going up or down stairs on the medial compartment, eventually led to the failure of that tibial component. Looking back at the literature in 2005, Dr. Chatterjee et al. Actually found 100% correlation between the fractured tibial components cemented and cementless, might I add. And that was a direct correlation with the lack of proximal tibial bony support, which I thought was an interesting finding. With this next slide, we talked about how we could track through the progression of X-rays, how the alignment went from a normally aligned knee back to a progressive varus deformity. And I wanted to break this down a little bit more and go into some of the calculations. So normally with knee replacement, you're trying to restore the normal anatomic axis. This is around 5 degrees of valgus. So naturally, normally you'll have a slight inward bend to your knees. That's completely fine. But what we saw between some of the X-rays taken at the 1-month post-op visit, where you have a relative restoration of that anatomic axis, and when they eventually came in to clinic for their chief complaint of the component fracture, you saw a significant regression from a valgus to a varus alignment. So going from a mean 1.8 valgus to an eventual 14.2. Now, that begs the question, what caused this regression back to the varus deformity, ultimately placing more pressure on that medial compartment? So sometimes it can be a failure existing varus deformity that we saw preoperatively, but given how the alignment looked on some of those 1-month post-op X-rays, that couldn't be the case. That begs the question, though, there could have been changes preoperatively that predisposed the bone to failure. And that's what I wanted to draw your attention to with this image here. We talked about briefly some of the sclerotic changes that you can see with bone-on-bone articulation. Now, what that can do is cause a potential compensatory weight-bearing reaction that affects some of the bone adjacent to it, just right underneath, possibly leading to that defect in the bone that we saw intraoperatively. And again, compounded with some of the asymmetrical forces you have with natural loading when you're standing, when you're sitting, this can eventually put undue stress on that inadequately aligned tibial component fracture, leading to that failure. I wanted to call back to the earlier pathological model by Dr. Lee et al. We went over earlier in the presentation. And I wanted to stress this portion here where we see the late stage osteoarthritis. We can see some of that sclerosis where there is thickening of that subchondral plate. Now that might be sort of a weird thing to say. Why do you have thickening in a progressive degeneration of the knee? But then it goes back to that compensatory reaction where to make up for the bone cysts here, the increased porousness, the multiple holes in the subchondral bone, as well as all this micro damage, it's almost a salvage reaction by the bone in an attempt to solidify what's left. Now, then again, this sclerotic reaction is not the same as what's seen in regular normal joint subchondral plate thickness here. This thickness here is more of a brittleness, something that has micro fractures throughout. So think about how this can affect implanting a tibial component on an already predisposed micro damaged bone. Next, I just wanted to briefly go over how patient comorbidities could also contribute to the mechanisms of failure that we saw with these two cases. Obesity was prevalent in 2 of our cases, and actually in our second case, there was a significant jump going from a 32 BMI to 36. This only compounds some of those compressive forces that you have on the tibial implant and multiplies some of the asymmetrical forces that you see running through the medial portion of the knee. Given that there was an eventual regression back to a varus deformity that makes the medial forces worse on that knee. I actually have a nice figure that can illustrate this well in the next slide here. But this is from Dr. Johnson's study on looking at the distribution of load across the knee. You can see when in the first figure here, in a static just standing position, in a normally aligned knee, you may have equal distribution of forces between the medial and lateral compartment. But when you are in a dynamic gait position, so anything other than standing still, even when you have a normally aligned knee, that force vector is mainly going to be putting force on this medial compartment. So you can imagine if this happens to a normally aligned knee, what it does with a varus aligned knee. That puts even more pressure on this medial side. So that just shows that this is going to be a recipe for disaster with the tibial component. Lastly, I just wanted to go over how some of the component design aspects could have caused this fatigue fracture of the tibial component we saw in a knee replacement. I wanted to highlight what first made this design special. One, it was 3D printed. Two, highly porous. Three, made out of titanium instead of the cobalt chrome status quo. Now with 3D printing, this has been around for knee replacements in the past probably 10 to 15 years. Now, it still is a relatively new technology, and we have yet to see more long-term studies that talk about the survivability of a 3D printed implant. So that's of some slight concern. Second one, highly porous. Just to give kind of a brief overview about how this is made, it's done through a sort of laser printing process through what's called additive manufacturing, where a laser creates the porous undersurface, sort of the holes that allow the interdigitation of that bony ingrowth over time. Now that process can weaken some of the titanium metal integrity when it's printed out with all of those micro porous hole structures it's trying to recreate, and ultimately possibly reduce the substrate thickness of that tibial component. And then lastly, with the option for titanium itself, we talked about how cobalt chromium can be a stronger metal, but metal strength may not be the issue. You can have the strongest metal ever in placing an implant, but if it never grows into the bone, then you're just doomed to fail. So titanium does have that opportunity for better bony ingrowth, but kind of leads back to the first two that we call, how is the titanium getting affected with the advent of 3D printing and the advent of implementing this highly porous structure through the laser printing process? And with our last bullet point, I kind of wanted to take a step back from the engineering and maybe go into the implantation process itself. We saw actually with these two cases, from the index procedure of their knee replacement to the revision, we saw an undersized tibial component where it actually had to be sized one size higher for the revision. That may indicate that there was a possible undersizing of that tibial component, causing inadequate coverage of the tibial plateau. So if you can think about it, having a smaller surface area of the tibial component, taking both the ground reaction forces as it goes to the tibia, as well as the weight-bearing forces as it transfers down through the femur, how it can eventually lead to failure of that metal. But in general, physicians try and they prefer slight undersizing versus oversizing. Having a more overhang of the tibial component can cause friction on some of the soft tissue and ligaments. So in general, it's safer to slightly undersize that component rather than oversize. Now, to bring it all together in conclusion, we've had the first cases of a fatigue fracture seen in a knee replacement of this design with a cementless, 3D printed, highly porous structure. We've attributed the cause of these fractures to be due to some of the cantilever forces interacting between the non-grown surfaces as well as ingrown surfaces, creating sort of a torsional stress on that component, leading to the eventual failure that occurred short-term. And given the short-term occurrence, we recommend routine surveillance of the knee replacements through radiographs and X-ray to ensure the proper alignment of those prosthetics, as well as adequate ingrowth around the structure but ultimately to reduce patient discomfort. All right, that is my presentation. Thank you for listening.
Awesome. Thank you, student Dr. Lam. Does anyone have any questions? Dr. Johnston?
Alan, I've got nothing to say other than to give you high compliments of how you presented this this presentation and this topic. I do have some questions. But I will tell you, I think the time that you spent during that gap year was valuable. You were very good at the depth of knowledge, your terminology, the command of your slides, and explaining what was done. So I learned a lot from you. So I want to say you did a very, very good job in your presentation. Now, I do have some questions that are mostly relevant to a preoperative and a postoperative setting, rather than the actual titanium and the equipment that's being placed in the knee. My question to you is a couple. Number one, the element of obesity. You had mentioned postoperative condition, and I didn't hear you claim the height of the patients. Were they six feet tall? Were they 4 or 5? What did the height have anything to do with what was implanted in the knee? That's one component. The other question I need to ask is, as your slides have pictorially illustrated, the progressive damage to normal bone. The architecture which osteoarthritis deteriorates does create abnormal bone formation. So my question to you is, you have mentioned the word porosity or porous. So were any of these or both of these cases, did they have an assessment of osteoporosis in creating this looser framework to attach the hardware into porotic bone? Do you understand my question?
Yeah, thank
Okay.
you for those awesome questions. I'll try my best to give you a good answer for that first one. So yeah, we did have the height and specific weight on file in terms of calculating those BMIs. Now, just from how I was working with the physician and asking him about some of the questions with leading to this revision surgery, I believe he was more concerned about some of the weight they held around themselves rather than the heights of the patient. I think
I
he
didn't
was.
imply that it was a major factor. I just wondered what size people. I got the obese part, but I didn't know how big they were.
Mm-hmm. Yeah, it should be in the patient records, but it was not something, the height wasn't something that we thought of as a significant contribution to the turnout of these cases.
Okay. How about the porosity then of the bone?
Mm-hmm. Yeah, that's another good question. So to my knowledge, I did not see any types of DEXA bone scans being performed to evaluate whether they had either osteoporosis or increased porosity of the bone structures. The physician actually mentioned before that it was something that you could see through the radiographs, where you could see maybe an evidence or an after effect of the osteoporosis where there's increased whitening of that. And I believe that during the preoperative looks at the radiographs, he did not deem it to be a significant, he did not see a significant amount of osteoporosis to the extent where he decided, okay, instead of a cementless knee replacement, we will try to do a cemented knee replacement, because that goes into the question of how good is the patient's bone stock to where we could do either the cementless or cemented variation.
Yes. Okay. Well, apparently the bulk of the weight, I guess the tibia was carrying the brunt of what came loose, or the apparatus in there. So there's something there that made it come loose, aside from alignment and progressive obesity and ongoing, quote, wear and tear. But I don't know anything about the surgical technique. I'm just questioning about the simplicity. You would think that even a DEXA scan or a T or Z score might have been assessed when you, prior to putting this hardware in, and then that would help, I would trust, make a decision to put in cement or not. I don't know why it would hurt to do it. Excellent presentation. Thank you very much.
Thank you, Dr. Johnson.
Does anybody else have any questions, comments? If not, thank you so much again, student Dr. Lam. That was a great presentation. Thank you everybody who joined us today during this talk. I noticed in the chat, somebody asked, how do you sign up? Go to the MKRC Canvas page. If you go to the flyer, SCLAM's flyer, there is a link at the bottom. It should take you to the MKRC Canvas page. If not, please email me. I'll get you connected to the right spot. I can also throw the link in the chat really quick. If you give me 2 seconds.
I just did that.
Perfect, thank you.
So student Dr. Lam, I had a question for you.
Yes.
This is research you did in your gap year. And you might know that Anne-Marie and I are driving the research week. I was wondering if you'd care to present this in a poster format for research week.
Yeah, that's in April, right? For KCU?
Yes.
Yeah, I would love to.
All right, stay tuned. There'll be an announcement regarding the mechanics of poster presentation. It just occurred to me as you were giving that amazing presentation that this would be great fodder for you to get an additional entry onto your CV.
Yeah, that sounds like a great opportunity.
Thank you, thank you.
Yes, thank you so much again. Last chance, any questions, anybody? Well, if not, thank you so much again to Dr. Lam. Thank you for everyone who joined us today. Look into maybe presenting. This could be you presenting, student doctors. With that, everybody have a great weekend. Thanks again.
Thank you. Bye.